This test is the valgus stress test, which is done in 0 degrees and 30 degrees of flexion. This is an assessment for one plane medial instability, which means that the tibia moves away from the femur on the medial side. And according to the McGee text, the examiner applies a valgus stress, pushes the knee immediately while the ankle is stabilized in slight lateral rotation, either with the hand or with the leg held between the examiner's arm and trunk. So the knee is first in full extension and then is slightly flexed to 30 degrees, so that is unlocked. It has been advocated that resting the test thigh on the table enables the patient to relax more, and it's easier for the examiner. You need to make sure to compare the involved and uninvolved side. And structures that are implicated if it's a positive at 0 degrees is MCL, posterior oblique ligament, posterior medial capsule, PCL, ACL, or medial capsular ligament. So again, after performing it at 0 degrees, repeat the test at 30 degrees to help isolate medial compartment ligaments. This next test is the Houston's valgus test, which can also be done at 0 degrees and 30 degrees. So it is similar to the traditional varus and valgus stress test, but the difference here is that you're going to be using the table to stabilize the thigh more. And with this one, we are going to do a valgus test, but instead of holding onto the ankle, we are going to grab the first metatarsal big toe. So your forces you're actually getting is coming more from the foot and the ankle, but it's still a valgus stress at the knee. So you can do this in 0 degrees and then repeat that in 30 degrees of flexion. So 0 degrees to begin with and then 30 degrees of flexion. So a positive finding on full extension, McGee text says that it is classified as a major disruption of the knee. And if the test is positive when we have the knee flexed at 30 degrees, these are the following structures that may have been injured, which is the MCL, posterior oblique ligament, PCL, and posterior medial capsule. The next test is the varus stress test, and this is an assessment for one plane lateral instability, where the tibia moves away from the femur in an excessive amount on the lateral aspect of the leg. And according to the McGee text, the examiner applies a varus stress at the knee while the ankle is stabilized, so pushing the knee laterally. The test is first done with the knee in full extension, 0 degrees, and also then with the knee in 30 degrees of flexion. So you want to also compare the uninvolved to the involved side and the structures that are implicated. If it's positive at 0 degrees, the potential possibilities are LCL, lateral capsular ligament, arcuate popliteus complex, ACL, PCL, and repeat the test at 30 degrees to further isolate the lateral compartment ligaments like LCL, arcuate popliteus complex, and lateral capsular ligament. And remember to have caution with this varus stress testing because it's less reliable than valgus testing, as you get many false negatives. The next test is Houston's varus test, which is also done at 0 degrees and 30 degrees. And to do the varus test, you stabilize now more at the 4th and the 5th metatarsals, and you're doing a varus stress, and you can be in 0 degrees and 30 degrees of flexion. And according to the McGee text, if the test is positive, and so when the tibia moves away from the femur when the varus stress is applied, so in extension, the following structures could also have been injured, which include fibular or LCL, posterior lateral capsule, arcuate popliteus complex, biceps femoris tendon, PCL, ACL, lateral gastrocnemius muscle, and the iliotibial band. So a positive test with that indicates major instability of the knee, and also if the test is positive when the knee is flexed at 30, Some of the structures that could have been injured are the LCL, posterior lateral capsule, arcuate popliteus complex, iliotibial band, and bicep femoris tendon. This test is the anterior drawer test, and this tests for one plane anterior instability. And with this, the patient is going to be flexed at 90 degrees at their knee, and their hip is flexed to 45 degrees. In this position, the ACL is almost parallel with the tibial plateau. And here we are going to get permission from the patient to sit onto their forefoot to stabilize the foot, and their foot is going to be in neutral rotation. So you are going to place your hands around the tibia to ensure that the hamstring muscles are relaxed. So you're going to have your fingers around the medial and lateral tibial plateau. Then the tibia is drawn or pulled forward on the femur. The normal amount of movement that should be present is about 6 millimeters, and according to the McGee text, if the test is positive, where the tibia moves forward more than 6 millimeters on the femur, then some of the following structures that can be injured are the ACL, postlateral capsule, posterior medial capsule, MCL, which are the deep fibers, the IT band, posterior oblique ligament, and arcuate popliteus complex. This is the Lachman test, which is a test for one plane anterior instability. And if you are checking for a possible ACL tear, this Lachman test is the gold standard. And so with this test, the patient is supine, and you want to have the patient also into some knee flexion. And you can also help by putting your leg and thigh underneath the patient's leg that you are testing. And then one hand is going to be at the distal femur to support, and then the other hand is now giving the anterior drawer test. According to the McGee text, in order to get the best results with this test, the tibia should be slightly laterally rotated, and the anterior tibial translation force that you're applying should be applied from the posterior medial aspect. And a positive sign will be indicated by a mushy or soft end field when the tibia is moved forward on the femur. Some of the following structures may have been injured when a positive sign is found is the ACL, posterior oblique ligament, and arcuate popliteus complex. This is the posterior drawer test. It is a test for one plane posterior instability. It has a similar test position setup as the anterior drawer test, but instead you are testing the PCL and providing a posterior translation of the tibia. So again, similarly to the anterior drawer test, you're going to bend the patient's knee and then get permission from the patient to sit on their feet. You're going to place your hands around the knee, similarly to the anterior drawer test again, and now we are pushing the tibia posteriorly. If there is excessive mobility and movement, that is considered a positive test that the PCL is not intact. So this is the Godfrey test. You can do this test if you want to check for more posterior instability of the knee. And so you're going to flex the patient's knee. So bend the leg up into 90 degrees of flexion at the hip and at the knee. And you're going to look at the tibia to see if there is a drop-off in relation to the patella. So you'll look for a sulcus there or a sag. That would be considered a positive finding for posterior instability. But with this, you have to be cautious because sometimes if the person has anterior instability, as soon as you have them up into flexion, it'll look like they've dropped back, but it's really because they have already been displaced anteriorly. And so another test you can do is you're going to have their foot down onto the table, but you're still going to have the knee in about 80-90 degrees of knee flexion. And here you're just going to look and see if there is a sag sign or where the tibia is dropping back in relation to the femur, and you have to compare the involved and uninvolved side. This is the Slocum test, and this is the anteromedial rotary instability. So if you suspect that the patient maybe has some multi-directional instability, you can combine different motions with your drawer test. So with this test, it's going to be similar to the anterior drawer test position. So the knee flexed at 80 to 90 degrees of flexion and hip at 45 degrees of flexion. But here the difference is before you do your anterior drawer test or stress testing, you're first going to internally rotate the tibia and the foot to about 30 degrees. And then after that, you're going to go and do the anterior drawer test. And if that's where the laxity is or that reproduces the patient's complaints, then that can indicate more lateral structures. And then after that, you can externally rotate about 15 degrees. So then here you're going to get extra rotation on the tibia. And then after that, repeat the anterior drawer test. This is called the pivot shift test. There are many versions of this test, and this tests for rotary instability, anterolateral. This is a test that is usually done by surgeons to patients after they have completed ACL repair while they are under anesthesia. It's not as good clinically because the patients tend to guard. It will pick up ACL deficiency, but the person or patient has to be relaxed. So it's not a very good test to do in the clinic. There are a couple ways to do this. One is to reduce a subluxation, while the other is to create a subluxation. So we will be doing the reduction test first. Here we start with the knee straight and then stabilize the lower leg, flexing the knee to 90 degrees while you medially rotate the tibia. So you are subluxing that lateral tibial plateau and feeling for a clunk or reduction. The next is subluxation, and here you start into flexion and then internally rotate the tibia while you give a valgus stress to the knee and extend the knee. Again, you are feeling for a clunk. This next test is the reverse pivot shift test, and here we are going to apply valgus force while pushing the knee into hyperextension from a slightly flexed position. And the difference with this one is that instead of internal rotation of the tibia, now we are externally rotating the tibia, and that's going to bias the test a little more for post-lateral versus the anterolateral instability. So this is the Thessali or Thessaly test, and this is a very common test to use, and it is the best choice for a meniscus test. So you can do this if you are looking to assess possible meniscus involvement. So you can perform this at 0 degrees and 20 degrees of flexion. So you normally perform the test standing in a single leg with 0 degrees and then repeat it into 20 degrees of flexion. But when the clinometrics, when you do it with 0 degrees, they're not so great. So typically you eliminate that portion and only do the 20 degrees of flexion at the knee. So you're going to have the patient stand on one leg and rest their hands onto you for support. And you want them to bend their knees at 20 degrees, and you're going to have them twist around with you so that their hips are facing you at all times. And here the person is basically twisting right over that meniscus. And while they are doing this, you're looking for any clicking, popping, or reproduction of their complaints, and that would be considered a positive test. So this next test is the McMurray test, and it's also a really good test if you're suspecting a meniscal lesion on the knee. And you can do this test looking for either a medial or lateral meniscus problem. So you're going to bend the patient's knee and hip at 90 and 90 degrees of flexion. And if you're trying to test for a medial meniscus problem, you'll externally rotate the tibia. And then if you are looking for a lateral meniscus problem, you're going to internally rotate the tibia. So we are going to test for the medial meniscus first. And here you're going to maintain that external rotation as you straighten your knee. And you want to have your fingers at the joint line because you are wanting to feel for a pop or a click. And you can also give a little bit of valgus force. So again, you're going to start an external rotation and then go into extension of the knee. So to do the McMurray's test on the lateral meniscus, you are going to internally rotate at the distal tibia and then have your thumb over the lateral joint line. And again, here you're still going to provide some valgus force while you extend the knee. So again, it is positive if a palpable or audible click or snap is reproduced. So this is the Apley test, and this is another test you can do when you are considering a possible meniscus involvement at the knee. And there are two different ways that you can perform this. You can do it as when you're applying distraction and then followed by external and internal rotation of the tibia, or you can apply compression, then do it again, external, internal rotation of the tibia. But for the meniscus, you are more going to do the Apley compression. So here you're going to have the patient prone and you're going to bend the knee into 90 degrees of flexion, and then you're going to compress straight down through the patient's calcaneus. After this, you can then grind on that meniscus and you're looking for reproduction of the patient's complaints of pain. So when you're doing the Apley test with distraction, then you are going to have to stabilize the person's thigh. And by doing this, you can use your thigh and place it onto theirs to stabilize. And what you're going to do is wrap your hand around their ankle so you can get a good grip for your distraction. And then after that, you can go ahead and do some internal and external rotation. And while you're doing this, you're going to see if this reproduces any of the patient's complaints of pain. This test is the Ecke test, and this is also considered the weight-bearing McMurray test, and this is also testing for either a medial meniscal lesion or lateral meniscus lesion. So if you are suspecting a medial meniscal lesion, you are going to externally rotate the tibia, and then you're going to have, while their feet are turned out, have them perform a squat as far as they can. And here you're looking for the reproduction of their complaints of pain at their joint line. And for testing the lateral meniscus, instead of external rotation, you are going to have the patient into internal rotation of the tibia. You're going to have them also, again, squat down and look for any reproduction of their complaints of pain at the joint line again. So a test for swelling is the brush stroke test, and this is a good test for assessing minimal effusion. And here you're going to begin by stroking the medial aspect of the knee, or milking the fluid to the lateral aspect of the capsule. And here you're looking for a bulge of fluid just lateral to the distal medial patella. So there is a grading scale with this, and so a trace is when there's a small wave with the downstroke, and then a 1 score is when you have a larger medial bulge with a downstroke, and then a score of 2 is when the effusion returns after the upstroke, so there's no need for the downstroke, and then a 3 is when the effusion is large, that it doesn't respond or move with the upstroke. And then if you can't even push up to the medial aspect of the knee, then that would be considered a 4. So another test for swelling is the patellar ballottement tap test, which is not really done often, but what you can do is have the patient with their knee in extension. You're going to use one hand to push down and hold inferiorly from the patella. So this is going to stabilize the patella, and with your other hand you're going to go superior to the patella and you're going to push down and hold. And next you're going to use your finger of your superior hand to tap onto the patella. In a normal knee, the patella should just move down into the femoral condyle when you tap down with your finger, but if there is swelling, then the patella is going to float, and that will be a positive test. So this next test is the patellar grind test, or the Clark test, and you can do this if you're trying to assess for possible patellar femoral alignment issues. And depending on the text, some will say that you come superior to the patella and compress, and some say that you go directly down onto the patella. So what you're going to do is you're going to compress and cup your hand over the patella, and you're going to have the patient, try to squeeze and tighten the top and anterior portion of their thigh, and in here you're going to look for any excessive crepitus. Also, if the patient has any complaints of their pain because you are providing the compression, you're compressing the patella against the femoral condyle and asking the person to do a quad set while you do that to see if you can reproduce any of their pain. So this test is the McConnell test for chondromalacia patella, and it is a really good test because it's more patient friendly, and it's good to do if you're testing for a possible patella femoral dysfunction. And you can do this in different angles of knee flexion because the way that the patella is sitting within the femoral condyle, there's different amounts of compression depending on the points of contact. So you start with the patient in 120 degrees of knee flexion, and then you resist them so they can perform isometric contraction, and then you're going to see if they have any complaints of pain. And then you will go into your next position if they don't have any complaints, and that would be 90 degrees, and same thing, resist them and create an isometric contraction. And again, if they do not have any pain at this point, go to the 60 degrees of flexion. And at the 60 degrees, they say that this is where they get some of their pain. But you take note of that, and then you go into 30 degrees of knee flexion, isometric contraction there, and then lastly go into full extension, and then resist and have them go into isometric contraction there. After that, you are going to go back to where they were painful, which this was at 60 degrees of flexion. So here you can use your leg to bring them out into that specific position so they can passively relax, and then before you have them isometrically contract and kick out, you're going to use the heel of your hand to push their patella medially, and once they kick out into your hand, if that is less painful than it was without the medial glide, then that is a positive test. So a test for ITB friction, you can do the Noble compression test, and you can have an IT band friction syndrome that could bother you at the hip, at the greater trochanter, but usually it manifests as lateral knee pain. You're going to have the patient in 90 degrees of hip and knee flexion. And with this, you are going to use your thumb and your web space to find the lateral femoral condyle, and you're just going to go off of that and apply some compression, and then you're going to bring the patient into some extension passively. So it is considered positive sign if the pain is noted near about 30 degrees because you start extending their knee and they say that their lateral knee pain has been reproduced. So that would be considered a positive test.